Thank you very much for this wonderful talk. And now there will be a panel discussion. And first of all, I would request Professor Khwaja Muhammad Azim to give a brief comment about this research work that we have done over the period of time in our surgery department. We have a bit of a problem. I mean, I would request, I have a question for Zatoon Zafar. Zatoon Zafar, can you unmute yourself?
Hello, Assalamu alaikum, sir.
Okay, Zatoon, here is a question for you. One of our attendees has asked, what is the difference between pre-audit and thyroidectomy difficulty scale? How would you compare both of them, and which one is better and why it is better?
Yes, first of all, the thyroidectomy scale of 2014 by Schneider, what it did was it's very restricted to the gland, and it only measures factors related to the gland during the operation and post-operatively. What we wanted to do with pre-audit is to measure based on patient factors as well as malignancy factors, in addition to the thyroid gland factors. We wanted to arrive at a conclusion pre-operatively and judge whether it was going to be difficult or not.
Okay, would you please start your video, unmute your video? Okay, that's so that everybody can see you.
No, I'm sorry, I cannot.
Okay, there is another question. What is it easy to predict the complication rates pre-operatively? And can you do it through pre-audit?
Well, that's what we made it. That's what we created the tool for, to judge whether the operation itself is going to be difficult. And we had our correlation coefficient showed that there was a strong association between the pre-audit score and the resulted complications.
Okay. And now there is a question for Dr. Safia Zahir. Dr. Safia Zahir, are you online?
Thank you so much, sir.
Okay. There is another question for Dr. Hadia Munir Beg. Dr. Hadia, can you unmute yourself, please?
Yes, hello.
Dr. Hadia Munir Beg, can you unmute, please? There is a question for you.
Yes.
Okay. How do you compare truncal venous branch ligation of inferior thyroid artery? I mean, does it affect in the long run, or it only affects the transient hypocalcemia?
Actually, in both groups, there was no difference in the permanent hypocalcemia, but we noticed some differences on day 2, in which the truncal ligation group had 36 patients who required patient therapy, whereas in the branch ligation group, only 5 patients required.
Okay. There is another question for Dr. Zatoon Zafar. And what do you mean by difficulty? What are the limitations for pre-audit score? Can you elaborate on, please?
One of the limitations, yes. One of the limitations of the score is that it was, we've only tested it in our hospital and not in other hospitals. Mm-hmm. That is one major limitation. And another would be that we need to perform more retrospective studies.
So what you're trying to say is that it is a less generalizable scale at the moment. It has to be validated in other settings as well, for example, in Western settings, so where actually the gland size is quite small.
Yes, in different hospitals and amongst different populations as well.
Okay, let me bring Professor Khwaja Azim here. He would like to talk about what are the important parameters which are important for determining the difficulty of operation.
Thank you very much. There are many factors to handle a difficult case of goiter, the first most important thing is the pathology of the thyroid gland. Regarding the carcinoma of the thyroid, if it is stage 3 or 4, involving the trachea, esophagus, strap muscles, carotid sheath, one has to be very careful to sacrifice certain structures, but not the vital structures. You need patience. You may deal with these technical difficulties with a great precision, and that can lead to disasters if you will not take care of the certain anatomical structures, because whatever the loss occurs, it may lead to a permanent loss, because the thyroid gland is riding off the two tubes, the trachea, esophagus, and on both the sides is the carotid sheath, where is the common carotid artery, and the encasement of that, you damage the carotid artery, 40% people, they develop hemiplegia. One thing. The second is the reductional goiter. You should don't put the finger by delivering the gland, because you can damage the recurrent nerve, because it lies on the posterior surface, or it's stuck to the posterior capsule of the thyroid gland. So you start at the superior pole, devascularize the gland by tying the inferior thyroid artery. Don't put the finger and you just put a taking sutures on the surface of the thyroid gland, and you should remain within the peritracheal fascia and deliver like the child from the womb. This is the only way you can avoid the injury to the recurrent nerve, which is much more vulnerable in case of retrosternal goiter. The third thing is the size of the gland. If the bigger the size of the gland, is difficult to do because it crosses the normal anatomical boundaries of its confineness. So one should be very careful for the regional anatomy, should be well versed with it, because the carotids, the brachial plexus, the trachea, the esophagus, and the vascularity of the gland, and the anatomical display of the structures, and perfect, complete, and compulsive hemostasis, that are the essential needs for a good thyroid surgeon to perform this thyroid surgery, because it will otherwise end in disasters. The fourth difficult index is that patient who has undergone previous operation. So that is the most difficult part on the part of the surgeon to operate, because of the extensive fibrosis, the loss of plane of the cleavage, the complete anatomical distortion of the various anatomical structures. They are not at their own places. Regarding these recurrent nerve, the parathyroids, the carotid sheath, they are displaced from its normal anatomical position. One has to be extraordinarily very careful about these vital structures, which can determine the end of the operations. The patient go from bad to worse. So redo surgery, no matter if for the cancer surgery or for the benign thyroid surgery, one should take a very extraordinary careful about the structure and very vigilant doing this thyroid surgery, because of loss of plane of cleavage in the redo surgery. The other important thing, which remember, a patient who has already one nerve is damaged, like maybe a carcinoma of the thyroid on previous thyroidectomy, so you have to operate on one nerve. So this is again a very challenging for the surgeons, and especially for the anesthetists. They are very worried, and actually the more worrying lie with these anesthetists rather than the surgeons. But we have done a number of the operation on one recurrent nerve, including the benign operations and as well as of the cancer patients. But one has to be very careful regarding the recumbent nerve and its course and its exposure right from the base of the neck till the entry into the larynx. And one should also be very careful about in these circumstances, sometimes you deal with the non-recurrent laryngeal nerve, and that nerve may be the only nerve which is there to save the vocal cords. Otherwise, you will end in acute respiratory insufficiency lead to tracheostomy. Fortunately, we have done a lot of redo surgery in Shalamar hospitals and also in the Mayo hospitals, and we were well versed with the uh, regional anatomy of this area of the head and neck, and that is the only way you can able to avoid the injuries to the vital structures if you know their exact anatomical place and the abnormal place. So there is no hard and fast rule in the redo surgery, in the cancer surgery, or in the retrosternal goiter. One has to very careful, and you will only say what you will see. You will not go by presumption that these structures are present here or there. No, you have to see it, and then you have to explain to it. So nothing presumptions. You have to be very, very careful. Head neck surgery is the most technical demanding discipline today for a variety of anatomical and pathological reasons, because there are a lot of veins and the artery and many structures going up or down the thorax, and they are very much vital because the important tubes are there, important vessels are there, which are vital to the human body, and if they have been damaged, they will adversely affect the morbidity of the patients, and sometimes you will find you may will end in disaster and make the patient crippled for the rest of life. Thank you.
What is the role of reductional extension in difficulty of the thyroidectomy?
The big problem is there that in the reductional goiter, the part which has gone inside the chest, the blood supply usually comes from the neck. The second thing is that if you will not devascularize the gland in the neck by tying the inferior thyroid artery, by tying the superior thyroid vessels, you should not allow to touch the gland and deliver with the finger, because this will end in disaster. You can damage the left brachiocephalic vein, which is crossing the superior mediastinum, and that will lead to disaster. You have to do the crash thoracotomy and sternotomy to get rid of these problems. So one should be extraordinarily meticulous, especially those goiter which are posterior mediastinal goiter, where in that situation you cannot deliver from the top. You have to do the sternotomy, and at times, sometimes you have to cut the left brachiocephalic vein to divide it, and you can then deliver the gland which is behind the left brachiocephalic vein. So that is the most difficult task for the surgeons, especially when the retrosternal goiter is the posterior mediastinal goiter, where the nerve is difficult to save, and over and above, sometimes a lot of difficulty. I think one should not take the risk of doing the cervical delivery of the retrosternal goiter when it has been established that this is a posterior mediastinal goiter, which is only in 10 to 15% of the cases. So one should be extraordinarily careful and ready for this turnover.
Would you like to share a few tips for preserving the vascular supply of the parathyroid glands? There is another question from an audience.
The one thing is very important. The main supply to the parathyroid gland is the inferior thyroid artery. The inferior thyroid artery you must locate first before you touch the parathyroid glands. Inferior thyroid artery lies in front of the spines in the perivertebral fascia, and it is coming behind the common carotid. This inferior thyroid artery has got a sheath. You must go within the sheath of the inferior thyroid artery, and then you put a loop around it so that you know this is inferior thyroid artery, main artery. Then you trace the branches. The first branch of the inferior thyroid artery is the parathyroid branch of the inferior thyroid artery. So you have to trace the branches of the inferior thyroid artery, and the first branch is usually supplied to the parathyroids. The superior parathyroid also gets the twig and blood supply from the posterior branch of the superior thyroid artery. If you preserve the parathyroid branches of the inferior thyroid artery and only tie the thyroid branches of the inferior thyroid artery, you probably can avoid the ischemia to the parathyroids, which will subsequently prevent the transient attack of death. I think it is very important that you should identify the inferior thyroid artery and identify the parathyroid branch of the inferior thyroid artery, and the field should be absolutely dry, and there should be complete and compulsive hemostasis as you are operating on the dead body. And then there is no need to tie the main trunk.
Would you like to share your experience with the preoperative use of the Lugol's iodine?
I think this Lugol's iodine is a blessing to operate upon the patient of thyrotoxicosis. You must use Lugol's iodine to reduce the vascularity of the thyroid gland, and the optimum time may be 10 to 14 days. This Lugol's iodine should not be started at the start of the treatment of thyrotoxicosis. It should be started when you have planned to do the operation at least 10 to 14 days prior to the operation. It will not only reduce the vascularity, but it does reduce the friability of the gland. It distends the follicles because of the deposition of the coli. It inhibits the proteolysis. Result of that, when the thyroid follicle distend, it will compress the surrounding tissue. So vessel compressed, and it will be very nice to do the operation when you have properly devasculated the gland. The tissue will get hold the stitch. Otherwise, it is very difficult because it's just like a friable tissue, just like a butter. So by giving the Lugol's iodine, it consolidates the tissue, and it is a better stuff for suturing if the need required. So I must say the Lugol's iodine is the essential to reduce the vascularity of the gland, especially in thyrotoxicosis. One should not, the young surgeon never touch the primary thyrotoxicosis without giving 10 to 14 days prior to the thyroid surgery in thyrotoxicosis. So most vascular gland in primary thyrotoxicosis.
Okay, there is another question. What is your policy about the drain placement thyroidectomy?
It's absolutely a controversial and debatable issue. One thing you should all remember for the young surgeons, you never regret by putting a drain for 12 to 24 hours. The placement of drain is controversial issue, because if you have got a perfect, complete compulsive hemostasis, the surgeon is very senior, which has tied the superior and the inferior thyroid veins, and the branch is very uh, comfortable, and there is no ooze at all. I think that you can avoid the drain, especially in lobectomy and hysterectomies. In total thyroidectomy, yes, at times when you think that the field is dry, you can avoid it. But I still believe that for the young surgeons, if they do the thyroid surgery, they will never regret by putting a drain. The purpose of putting the drain is that it will allow the hemorrhage. If you look at the drain, sometimes the initial bleeding is there, you will know the blood is coming there, and you can go and take the operation theater. But one thing is very clear: when the hemorrhage occurred, the drain stopped working because the blood clots. It is the neck swelling and stridor and the respiratory distress, which will clinch the diagnosis if the patient has got post-operative hemorrhage. So it is not a hard and fast rule. But one thing you should remember, you never regret by putting a drain for 12 to 24 hours. One thing is very important. This, by placement of a drain, you will reduce two things: post-operative discomfort, and the second is the incidence of seroma has remarkably reduced. Otherwise, you have to aspirate the serum post-operatively after 48 hours, put a needle there, and you aspirate for 10 to 15 cc. Sometimes the people, they say, what is this, blood is coming out. But anyhow, this is a normal practice. If you don't place the drain, then you have to aspirate the seroma post-operatively after 24 to 36 hours. And
Thank you
that
very
is
much.
not good.
Thank you very much. Drain placement can prevent seroma formation, but it does not prevent the hemorrhage. So it has to be a careful decision when
It is on the operation table.
Okay, so we will move on now, and our next speaker is Dr.